B12. It's a small molecule, but has this huge clinical impact.
Absolutely huge.
And we're going to explore its therapy using a kind of clinical flowchart approach, like the practical breakdowns you might find helpful, maybe on channels such as KMR Advice, designed to make complex stuff clearer.
Exactly. And our mission here is really to walk through that flow, step by step, understand how B12 therapy actually works, from getting it to seeing the effects, and importantly, how we monitor it.
I really like using flowcharts for this stuff. It just lays out the whole journey so clearly.
It does. And following that flow, well, it reveals some critical clinical thinking points. So where do we start on this chart?
Right. Step one is basically getting the B12 into the patient. Administration. The source talks about different forms: cyanocobalamin, hydroxycobalamin, methylcobalamin too.
And the different ways to give it: oral or intramuscular IM, or sometimes even IV, intravenous.
Okay, so once it's administered, what's next? Getting it absorbed, I guess.
Precisely. Absorption and getting it into the systemic circulation.
Yeah.
Now, if it's given orally, there's a specific mechanism. It absolutely needs something called intrinsic factor.
Intrinsic factor produced in the stomach, right?
Yes. And it helps the B12 get absorbed, mainly way down in the terminal ileum.
That's such a key detail because, as the flu chart points out, if that system's broken, like in pernicious anemia where you don't make intrinsic factor.
Or if someone's had surgery, like a gastrectomy removing the stomach, or maybe an ileal resection removing that part of the bowel.
Then oral B12 just won't be absorbed properly.
Exactly. Absorption will be poor. So in those cases, you have to bypass the gut. IM or IV becomes essential. That's a really fundamental decision point in clinic.
Makes sense. So, okay, it's absorbed or injected, it's in the blood. How does it get where it needs to go?
Good question. Transport is next. It doesn't just float around freely. It binds mainly to a specific protein called transcobalamin 2, or TC2.
TCC2, like its dedicated taxi service.
Sort of, yeah. It's the key delivery protein to get B12 into the tissues, the cells that actually need it.
Okay, so it arrives at the cells. What happens then? Cellular uptake.
Right. Cells take it up through specific receptors. It's receptor-mediated endocytosis. Then inside the cell, this is where the really crucial stuff happens.
The activation.
Yes. B12 gets converted into its active coenzyme forms, methylcobalamin and adenosylcobalamin.
And these are the forms that actually do things in the body, right? This connects to the symptoms people get when they're deficient.
Precisely. They act as essential coenzymes for two critical metabolic pathways. Methylcobalamin helps convert homocysteine to methionine that's vital for things like DNA synthesis.
And the other one, adenosylcobalamin.
That one's needed to convert methylmalonyl-CoA to succinyl-CoA. That's important in fatty acid metabolism. You can think of homocysteine and methylmalonic acid, MMA, as markers. When B12 is low, these build up.
Like warning signs.
Exactly. Warning signs that these vital pathways are blocked.
And that blockage explains the clinical problems, like the impact on red blood cells.
Yes. B12 is essential for normal red blood cell maturation in the bone marrow. Without it, you get megaloblastic anemia, large immature red cells.
And the neurological problems too. That's the myelin link.
Correct. It's crucial for myelin synthesis and just maintaining healthy nerve function overall. Lack of B12 can really damage nerves.
So when therapy starts, we expect to see improvements in both those areas.
Definitely. You see the megaloblastic anemia correcting, and neurological symptoms like tingling, numbness, paresthesia, or balance problems, ataxia, memory issues. Those should improve.
The source mentioned some timelines for seeing effects.
It did. You often see the reticulocyte count, that's a measure of new red blood cell production, jump up within about 5 to 7 days.
That's quite fast.
It is. And the hemoglobin level itself starts to rise usually within 2 to 4 weeks.
Okay, so how do we track this? How do we monitor the therapy?
Monitoring involves both clinical assessment, are the symptoms getting better, and lab tests. The flow chart points to key markers.
Which ones?
Reticulocyte count, like we said, hemoglobin, MCV, the mean corpuscular volume, which should decrease from being high, serum B12 levels themselves, and those markers we mentioned, methylmalonic acid and homocysteine, should ideally normalize.
And how long does treatment last?
Well, it depends on the cause. If it's something irreversible, like pernicious anemia, then therapy is generally lifelong.
Right. Is B12 therapy safe? Any side effects to watch for?
Generally, it's very well tolerated, really safe. But the flowchart does note some rare possibilities, things like pain at the injection site if it's given IM.
Okay.
Very rarely. Hypersensitivity reactions. And one thing to watch for, particularly if correcting severe anemia rapidly, is hypokalemia, low potassium levels.
Okay. Worth knowing.
And extremely rare high-dose effects like certain skin issues, acne, or rosacea, but that's really uncommon.
Are there specific groups of people we should be particularly thinking about for B12 issues or needing therapy?
Yes, absolutely. Special situations, pernicious anemia, obviously, people who've had gastrectomy or ileal resection surgery. Anyone with significant malabsorption, they'll likely need parenteral injectable B12.
Okay. Any others?
Definitely. Vegetarians, and particularly vegans, as B12 is mainly from animal sources. The elderly, due to absorption issues sometimes. Chronic alcoholism can interfere. Pregnant or lactating women have increased needs. And, importantly, drug-induced deficiency.
Oh, right. Medications can cause B12 deficiency. Which ones should we remember?
The source specifically calls out metformin, which is very common.
Mm-hmm.
Also, long-term use of acid reducers like PPIs, proton pump inhibitors, and H2 blockers. They reduce stomach acid needed to release B12 from food.
Wow. And even nitrous oxide abuse.
Yes, that can inactivate B12. It's a really important list for clinicians to keep in mind.
Definitely. So finally, what are the main risks or complications if B12 deficiency isn't treated properly or quickly enough?
The big one, the most serious, is irreversible neurological damage. If treatment is delayed too long, the nerve damage might not fully recover. That's critical.
So early detection is key.
Absolutely. Another potential issue is that correcting B12 can sometimes unmask an underlying folate deficiency because their metabolism is linked. So you need to think about other deficiencies too. Always investigate the underlying cause.
Okay, so we've really walked through that whole flow chart
Mhm.
from giving B12, how it works at a cell level, the clinical effects, monitoring potential issues, the whole sequence.
And understanding that flow, that sequence, much like you learn from resources like KMR Advise,
Right.
is so valuable for medical students, for practitioners. It genuinely impacts how you diagnose, how you treat, and ultimately patient outcomes.
Totally